Hello and welcome to yet another lecture number 28, and this is on a very interesting topic, which is nursing. And as we all know, nursing is one of the most essential and really close to people aspects of the modern healthcare system, whether it's the public health system or private healthcare. And of course, the place and presence of nurses, their importance was most vividly seen and felt by all of us during the recent COVID pandemic. So they were the most visible face. So we saw them doing human service all over the place. But now getting back to our topic, which is the colonial period. So with regard to its advent, of course, professional nursing, as like many other things related to medicine, came during the colonial period. So initially, in the colonial period, the British women in India performed basic nursing and midwifery in the British households within India. With regard to Indians, that is nursing care for Indians, the British nuns and missionary women offered nursing services to the ailing natives of India. That was part of their missionary activities. But all of these kind of early, what we call the nursing duties, was not actually very professional. It was very unprofessional, untrained form of nursing, because these women were not professionally qualified or certified nurses. And from the mid 19th century, there were some scattered attempts for providing trained female nurses for government hospitals. And again, in this also, as in several other matters, the government relied heavily on philanthropic efforts, and getting money and subscription from good intention public, both native or Englishmen, so rather than the government getting too committed. So the Calcutta Hospital Nurses Institution was established in 1859 through such kind of efforts, private efforts, through the efforts of the Bishop of Calcutta, Bishop Cotton, and some other British women in Calcutta. So this was a private charity which recruited as well as trained nurses free of charge, and provided nurses for the European as well as native wards of the Medical College Hospital, the Calcutta Medical College Hospital, and the Calcutta Presidency's GH. They also provided private duty nursing for the home care of Europeans with a moderate charge. And this system was also availed not only by the whites or Europeans, but even the nobility, some of the princes or the elite among the Indians, the rich people also availed of it. And as we all know, there was a major shift in healthcare in general after 1858 with the coming of the Crown rule, with particular interest on the health of British troops. And as we have seen, there was this famous sanitary commission appointed, which you also saw as the mother of all commissions, the first of those commissions, inaugurating the culture of commissions for studying various things like the famine commission or plague commission and other such things. So Florence Nightingale, who in fact suggested to the commission that a few matrons and head nurses should be sent from England for training of nurses in civil hospitals here in India. But the plan was rejected, again, same grounds, financial grounds. But in Madras Presidency, the then Governor Lord Napier, who was in fact personally acquainted with Florence Nightingale and her medical works on the war front, so he took special interest in nursing in his presidency, and in fact went ahead and appointed a permanent nursing staff at the General Hospital in Madras in 1870, and the training of the nurse probationers began in 1871. These kinds of efforts also started in other places. So, this we will see in detail in another exclusive lecture on women's medical education, where we will talk about nursing education as well. Then there was something called the Upcountry Nursing Association, which was established in 1892. This was again to provide personal nursing care, mainly for Europeans on the basis of subscription. In 1904, the Lady Ampthill Nursing Institute was founded in Madras on the same model. In 1906, the Lady Minto Indian Nursing Association was founded by Lady Minto, wife of Lord Minto, the Viceroy. So, this incorporated the Upcountry Nursing Association into it. So, what was the subscription model? So, those with a monthly income of less than 500 paid an annual membership subscription of rupees 10, and they paid rupees 20 if the income exceeded rupees 500. So, members were entitled to the services of a fully qualified nursing sister in times of illness for a payment of rupees 2. That is, if you had paid subscription of rupees 10 monthly, or rupees 4 for the other group. So, this was the daily payment to be made for nursing service. And if non-members wanted to avail of the service of these trained nurses, they had to pay 8 rupees for each day of the attendance of the nurse. And the nurses themselves were paid rupees 85 per month. They were also given quarters. So, who were these ladies? So, they were basically English ladies with 3 years training completed in England or in recognized Indian hospitals, and also with 1 year experience in private nursing. By 1914, the Lady Minto Indian Nursing Association had branches in the United Province, the Central Provinces, Punjab, Assam, Bengal, and Rajputana. And missionaries contributed substantially in building the local corps of nurses, so which again will be dealt with in detail in the lecture on non-state initiatives, where we will particularly talk about missionary roles. And apart from missionaries, there were also many social reformers and philanthropic organizations which also contributed to the building of indigenous nursing corps. So, this again will be detailed in the lecture on non-state initiatives. So, coming to the beginning of the 20th century, professionalization of the nursing duty profession acquired greater attention. So, till then there was no uniform standard of training, so much so that unqualified nurses would frequently turn out and pose as certified nurses and claim the same fees as properly and highly trained English nurses. So, the reason for this was put on the blame for this was put on the small scattered training and licensing centers here and there. So, therefore, there was a call for certification to be provided by a single examining board. So, each province should have its board for certifying the nurses. And another important step in this direction of professionalization was the starting of the Trained Nurses Association of India, which was started in 1908, with nurses employed by both missionary groups as well as by the government in the different parts of India. So, one of the important purposes and goals of the TNAA was to lay down a proper code of rules for nurses training as well as their professional conduct, therefore holding up to particular levels of standard. So, this can be seen as a reflection of further professional identity of the nurses in India. And this kind of professionalization was even further visible with the coming of the pioneering act called the Madras Nurses and Midwives Act, which came in the Madras Presidency in 1926. And this act provided for a council, that is the Provincial Nurses and Midwives Council, and mandated the registration of all the trained nurses. And strict penalties were introduced for dishonest use of certificates or false claims of having certificates, producing fake certificates and other such things. So similar kinds of provincial acts as was done in Madras Presidency were introduced in other provinces or presidencies, like in Punjab in 1932, United Provinces in 1933, Bengal in 1934, and Bombay Presidency in 1935. Yet another dimension of professionalization is the aiming for education and training in standardized forms. So we'll talk about the nursing training and education in greater detail in the lecture on women's medical education. But we should say here that the conditions of those training are very arduous. So even as they were studying in a particular institution, so they would also be made to work as nurses in the corresponding hospital. So while they were students, or sometimes more than students, they were also treated as employees. And the accommodation provided for the pupils in these kinds of institutions was overcrowded and was also extremely unsatisfactory in other ways. So these conditions made nursing a not so attractive vocation. But apart from this, there are also several other social and religious aspects which stood on the way of nursing acquiring greater attraction as a vocation. So employment of women in public environment was itself seen as something generally undesirable. So we were talking about women having to be kept under the protective care of their menfolk, and preferably in the zenana, in the isolated quarters. So going to the public arena itself was a kind of anathema. And then this was particularly so because in this profession, the women are also getting in closer touch with strangers and also with those of the opposite sex. And the dressing of the nurse, the uniform attire of the nurses was also something different from the traditional indigenous culture. So that was also challenging in its own way. And nursing women's morality was often doubted. So in fact, they were, even because they were coming in close contact with men and moving around closely. So you should also see all these things in the context of those times. So it may not appear that significant if you see it from today's point of view. But if you go back to that time and that kind of zenana and that kind of seclusion and preventing women from men's gaze and eyes and all that, so this is something even alarming. Ladies going and talking and touching men, and so there was a connection made that this would create the kind of mental and other kind of situation for getting into all kinds of sexual licentiousness. And in fact, the suspicion gained credence because, in fact, actually, several nurses, because of their low pay, did actually, maybe for the same reasons just mentioned, because they felt more free and comfortable. And didn't feel that much of an earlier social stigma, and also because of the compulsion of the low pay and trying to make their ends meet. So they did resort to prostitution. So generally, that stigma get attached to the overall profession as nurses being women of loose morals and licentiousness, and to be kept and seen with care and distance. So therefore, there was a very clear image problem. So with nursing being seen as something very inappropriate for women from respectable families. Not surprising, therefore, that for a long time those who took to the profession were from among the Europeans and the Anglo-Indian community. And apart from this gender issue, caste also played its part, because the majority of the Indian nurses were basically converts to Christianity from lower caste, or they were widows, orphans, or destitute women. So who took to nursing because they had no other option. So in that sense, for that kind of women, nursing provided some kind of a opportunity for social mobility in spite of all the stigma and all that. And since we mentioned widows, so widows as nurses was another cultural roadblock. So as they were considered, widows generally were considered as inauspicious and were generally subject to social exclusion. And another problem with on the way of nursing becoming an attractive profession was that it was seen as a kind of a menial servant level work, as nurses were working in very closely with low caste servants who performed menial work in the hospital wards, and therefore the profession itself, nursing profession itself, continued to be regarded as a low status job for minimally educated women and women from lower caste, and not something which is suitable for middle class educated women of higher caste. So the nurses were stigmatized like the dais who we came across in another lecture, the traditional midwives, as both were seen associated with impurity, because they were coming in contact with bodily fluids and particularly blood, which was considered polluting according to religious ideas relating to purity. And due to association with untouchability, the Indian nurses try to distance themselves from the polluting aspect of their work by delegating bedpan and other kind of works like giving bath to the patients. These kinds of works were consciously relegated to the sweepers or ward boys, and the nurses avoided doing it because then they were seen as belonging to untouchable caste. And also there's another problem because nursing does not necessarily need to be done by women. In fact, in the for instance, the army, this kinds of medical attention was given to brother soldiers by male orderlies. But in course of time, so nursing itself had acquired that feminine slant, so which meant that it did not attract male candidates, as it was seen as something for women, and also women of a particular kind of background. So looking at all this, the Council of Medical Women in India, so they took upon themselves as a responsibility to improve the status of their sister profession by encouraging, by creating all kinds of situations which would generate a more respectful attitude towards nursing rather than the very stigmatized way in which it was being looked. So they also insisted, so this council members also insisted on adequate staffing of hospitals with well-educated and well-trained nurses. They also called for provision of better living conditions, especially for students, and an increase in the scale of pay for the staff nurses, sisters, and the nursing superintendents. In terms of training, they call for nurses training schools to have properly qualified sister tutors, and also with facilities for specialist training such as for theatre work. Trained nurses were to be included as inspectors of the training schools, and also in all the boards of examiners, the majority of the members were to be nurses themselves. And trained nurses were to be appointed as registrars to all the provincial nurses registration councils. However, the colonial state showed a lack of commitment towards nursing, as it did through several aspects of healthcare in general. Again, so you know the reason, prime reason, financial reason. So it was reluctant to incur expenses to rectify these kinds of problems in the field. And as in some other matters in healthcare, so it sought to put the blame on the natives. So it pointed its finger to the cultural reservations on nursing, which we discussed earlier. So this was used as an excuse to justify its lack of political and financial commitment to nursing, saying that so Indians themselves are a roadblock to the development of the profession, all that. So this reluctance of the government or the failure of the government to engage with the problems in nursing, so resulted in further reinforcing the negative stereotypes regarding nursing. So thus the profession remained unable to meet the public health demands of the Indian population, so much so that by the time of around independence, there was only one nurse for every 43,000 people in India. The Boer Committee report, so the Boer Committee was appointed around the time of independence to see the existing state of healthcare and more importantly to suggest means to go forward as to lay a kind of a blueprint, all-round blueprint for health for the new independent nation to be. And so they spoke particularly about nursing as well in their report of 1946. So they recognized the agenda of the nursing leadership by recommending that trained nurses with advanced qualifications were to cater to rural and urban public health in India. So this report supported the creation of the All India Nursing Council, which would work for the standardization of nursing education and against the exploitation of nursing students in different ways. For independent India, this served as a professionalized model for nursing to be considered for the country's healthcare system. So whatever we have today was to a great extent born out of this study, which looked at several aspects of nursing at that time with all its problems, and came up with these kinds of remedial measures. So if nursing today forms such a big backbone of the medical profession, both in the private and public sector, it's all owed to several of these things which happen, both the good things and the bad things, and the lessons that were learned from them. So this is, of course, so we can't deny the fact that this was another outcome of the colonial experience. So of course, traditionally we had our own forms of caregiving, but this kind of just as a professionalized midwifery came. So this was a professionalized, and as we will see in the lecture on nursing training, so there are different aspects in which they were trained, including vaccination. So this kind of professionalized nursing was a direct outcome of the colonial experience, and we will continue to see more of it in that lecture on nursing education. And on that note, we will close here. Thank you.